I'd like to thank the Southern Health and Social Care Trust for giving me this opportunity, because I'm just so delighted there's so many people here, and a little bit daunted, if I'm to be truthful, but I really just want to share some of my experience, and if it can help and support you to feel more confident and comfortable when you're working with people with MND, well then I know that's what I wanted to achieve. So I'm going to talk a little bit about the psychosocial impact, and a lot of speakers today, they've brought it up. We've been talking about anxiety, we've talked about suicidal ideation and depression, so I'm going to talk a little bit about it, but look from the different perspectives. So what's it like for the person with MND? Researchers, what do the researchers are saying, and what are healthcare professionals saying? And then I'm going to do a little bit of interactive work with you around the psychosocial approaches, because a lot of you here work in palliative care, you're working in the health services area, you have a lot of experience. So that's something to think of. Yes, MND has specific, unique aspects, but you also have other competencies. So we'll just talk a little bit about that. And then I suppose, I'm just going to encourage you, when you're working with people with MND, to always see if there is an opportunity to support the person from a psychosocial aspect. Because I think Marie spoke really well about the adjustments people have to make. Every day is a loss. Today is their best day. So it's just to be aware of that when you're working with people. So from the psychosocial impact, very kindly Loretta Dempsey has provided this video, if I can work it.
I don't feel sorry for myself often, but on occasion I have thought that it's a bit unfair that, as well as dying relatively young, you have to die wasting away slowly. Probably the worst thing about MND is watching my family, my mother and father in particular, do everything for me. I thank God that they are fit and healthy. Stop.
Okay. So Loretta allowed us to use this from an education perspective, and she died with MND last year. But it's just interesting what she's saying, about the condition. And then from what does the research say, and I have a lot of references to the different researchers' papers at the end of the presentation, but the psychological distress, the depression, anxiety, the sense of hopelessness that is engendered that can lead to suicidal considerations. And another thing, I suppose, that is something that comes out very much with motor neuron disease is that sense of being, demoralization, loss of meaning, that it's considered more than being depressed. And I suppose looking at it from the perspective of the person with MND, I know today, which is very important, we've talked a lot about the physical symptoms and how we can provide the best care for somebody from a physical symptom perspective. But research has shown that people start to move their perspective, from the physical to the emotional and the psychological, and often research has shown they can be dissatisfied with the level of care that's provided. So it's just something to be real provocative, in our heads. And then from the healthcare professional perspective, this is based on published research I did with counsellors, psychologists and psychotherapists in Ireland, and also with one or two from the UK and Italy. And they were just talking about, well, what is it like? How do they perceive? What's the experience? So when they're working with people with MND, they say a lot of it is, they have read enough about the illness. They know what is going to happen, okay? And then others say he didn't want to know, he didn't want to know, he didn't want to know what was ahead of him. So some of the things that they perceived was happening when they were working psychosocially with somebody with MND is, this movement from confronting it, I have MND, this is what's going to happen, and avoidance. And it's something we all do ourselves every day of our life, but it's a big swing for them. The fear aspect, for anybody who's working with people with motor neuron disease, you probably have come across the levels of anxiety, the levels of fear, and then, anecdotally, when I was working in the hospice, when people with MND came in for respite care, a lot of the palliative care team would say, oh, you know, they're very controlling. You know, they like to have things a certain way, and if I move something, you know, it becomes an issue. But I think if you can try and understand why they have that, want that level of control, because their level of fear and anxiety can be very, very high, then I think as a healthcare professional, you can try and work with the person to see, well, how can you support them to feel more empowered and in control? There's a lot of frustration and resistance, and I suppose the shame as well and the self-blame. And I think it's something that you know, from my experience, people feel like I'm a burden, you know, and also the shame of going out and not looking the way I used to look. Or I go down the street, you know, one man told me, you know, on my wheelchair, motorised, and, you know, I thought everybody's looking at me and I look different and I might be drooling, you know, and my speech might not be audible. So it's just to be aware of those things when you're working with people. So I suppose for you now, right, when you are, what's your experience? What's the first thing that happens to you? Say some of you have maybe worked with a lot of people with MND and some have no experience or some experience. So when you know somebody is coming in and you're going to be supporting them, what's the first reaction? Those who, you know, anybody? Sympathy. Okay, thank you. Okay, anybody else? I know it's after lunch, but I'm going to make it. I'm going to provoke you to do some thinking.
Even I'm really experienced motor disease. Sometimes I feel uncomfortable and discomfort if I'm dealing with someone who's really young, for instance, or
Thank you, John. Thank you, John. And so, you know, somebody who's worked a lot with people with motor neuron disease, still feeling uncomfortable. I know I do. Every time I meet somebody new and I hadn't worked with them before, my level of discomfort, not knowing, you know, what they need, how can I support them, what way is the condition going to have affected them? Anybody else?
You're conscious that you're working with someone who doesn't have long there.
Yeah.
It's a cruel condition. Very
Yeah.
cruel.
Yeah. Thank you.
Could be any one of us.
Okay.
You know,
Yeah.
somebody so young, you know,
Yeah.
brothers, sisters, family members.
Yeah.
And I suppose the media on the TV, you know, there's different programs for young people, and
Yeah.
not just young, but I think it just puts life in perspective.
It does, yeah. Yeah.
Sometimes you don't know what they know or what has been explained to them
Mm.
and how far you can go with talking to them.
Okay. Yeah.
I think you need not to rush them, to be patient with them, because it's slow to communicate, so you have to give them time as they get to it.
Yeah. Yeah. So lots of different perspectives, and all, I suppose, you know, based on experience. And you know, some of the things, like you know, people saying, you know, it's an awful, you know, this was a comment from somebody who worked with people a lot as a healthcare professional, and you know, he was mentioning it's a horrific disease, and it still hasn't left him. So every time, you know. And then people say it's privileged work, and I'm working with somebody and I'm going to help them on the journey. So for people, the healthcare professionals and specifically therapists working psychologically, they were moving from a feeling of, you know, sometimes it's quite horrific. It can be horrific. And it's also a privilege. So they can move between that. They can feel a real sense of loneliness, that they're alone in this, and they can start also avoiding the person, you know, and you may not be avoiding them. You think, oh well, I'm physically there, but you might be a little bit more detached from them, and maybe not allowing them the space to say what maybe they need to say. You can feel a great sense of sadness, and you can really connect with people. But they also talked a lot about, you know, the feeling of anxiety. As a healthcare professional working with feeling very anxious, and working to appease the person as well, which sometimes isn't always the best way of working, but you know, So it's just very interesting what they talk. So the key points is that I suppose MND is an illness that is particularly prone to that sense of helplessness and failure in healthcare professionals. So you can feel that, and also it can often lead you then to feeling a bit frustrated. You can feel, I'm not skilled enough, and you can start avoiding people with MND. And so these are all normal reactions, so I'm just saying what's happening is completely normal. And I suppose the main thing is as a person, healthcare professional working in this area, you need to feel comfortable. That's why today is such a great opportunity to share experience and share learnings, so we can all gain a little bit more comfort and competence, the main thing, when we're working with people. So the psychosocial approaches, I suppose, the different types of interventions. From the research, reviews show there is an absence of proven interventions in the area. Some of the things that they are looking at are the psychotherapies, social support enablers, decision supports, and improvements in the healthcare delivery. In the psychotherapy approaches, there's no consensus about a specific approach due to the fact that, everybody's unique, and also the motor neuron disease progression can be unique for the person, and it has a variety of presentations. Common approaches from the research shows, though, if you support the person where they are now, so, try and see them, where are they now? Making sure that you are empowering them. John talked about advocacy, but giving them the sense of they have an ability to have an active role in their life. And especially after diagnosis, that can feel like, it can take time for the person to feel a little bit more in control and making the different directions in their life to bring that in. And as well as, giving the person space to explore what is going on for them. And I suppose as well, the palliative care approach, which we're talking about, and, I've seen, and it is mixed, some people won't want to access it, some people will. And when you can work with someone around the fear of palliative care, it's like the All Ireland Institute has a Palliative Care Awareness Week on, to try and break down the myths around palliative care, about what have you heard, to try and make it, because I suppose I was lucky that when I was working with people, I had worked in the hospice organisation, so I could even discuss what actually happens in the daycare and what services could be there to support you. Because with motor neuron disease, some of those daycare support services can be really useful. And making sure you ask people what they need and what they want. So just back to this. If I can get it to work. So Loretto, this is just another one I just wanted to play for you.
Sometimes when I can't move my hand, I think it can't get any worse than this. And then it dawns on me that it's going to get a lot worse than this. One day I won't be able to move my arm, even my hand. That scares me, but I have to believe that I will get through it one day at a time. Stop.
So, Loretto's talking there about just being the one day at a time, not thinking too much about what is happening in the future. And that, I suppose as well, people will have fears about the future, and being able to support them when they want to discuss that as well. So, and we've talked a little bit about this, but how do you think that feeling, because, often motor neuron disease, they call it a condition that is a series of losses. Every day is a loss. And, I think Marie really spoke very well about that transition for some people who may need to use a wheelchair. And how is that presented? And how is that supported? So, it really impacts the way the person relates to healthcare services. And we kind of talked a little bit about this. But, from the research, they say that one of the things, the way people adapt to loss, is they try and exert control in care. Okay, and some of you may have experienced this. I don't know whether you have. Yeah, see some nods. Yeah. And you know, if you're in the palliative care area and you've worked with other conditions, everybody's unique, but it can be a little bit different sometimes. And that gives them a feeling of being in control of their care, which is very important. And that they render control on their own terms. And that fosters a sense of control in the person. So there's a very good paper here by Ger Foley, and they've done an awful lot of work with Orla Hardman and the group in neurologists in Ireland in this area around the whole issue of control. So it's very good learning, and I've put the references there at the end. So, back out to the audience again. How would you support someone with MND who is experiencing anxiety? How do you think you'd support them? Listening, yeah.
Allowing them to be anxious, not saying don't worry, don't be upset, don't allow them to express how they're feeling.
Yeah. Thanks, Fiona. Yeah.
Make them aware of the services that's available to them.
Yeah.
And how to access those services.
Yeah.
Pharmacological and non-pharmacological approach instead of.
Yeah. Okay.
Control of your decisions and the way the conversation goes.
Yeah. So actually, you don't need me here because you see, you have a lot of the answers. You know, some of the things is, and you know, you talked about it, is providing that safe space. You know, use calm, positive statements. Slow down. Somebody mentioned that, you know, taking your time. Slow down. And I know that's very difficult when you're a healthcare professional working within the health services that are very much stretched. But it's just to think that few minutes extra with the person and giving them space. And I suppose, you know, we talked about it there, to support the person to talk about what they're feeling. And somebody else mentioned it. Is their fear a practical problem? And that if it was dealt with, it could relieve their anxiety. Because, you know, it's very important that you see the person. You know, that's a person, yes, they have MND, but they are a person, and they have a whole identity, and they have a whole life. And they have that life during motor neuron disease. And a lot of the time when I was working with people, you know, sometimes it was about motor neuron disease. Sometimes it was financial pressures. It was, how's my family going to be supported? It could be that feeling around a loss of identity. You know, it can be very much held in, you know, my job, now my job is gone. Your sexual identity, all of these things become very, you know, things that you need to think of. And I suppose one of the things that really encourage you to do, which you're probably all doing anyway, is, you know, discuss with your team. You know, get the support from your colleagues. You know, if somebody is feeling very anxious of that, say, have you noticed? What did you know? And think about, it could be a physical symptom, you know, so make sure you've checked all of that. Could you give them, do they need something else? You know, somebody talked about pharmacological and non-pharmacological supports. Would it be really helpful for them to see somebody and sit down who has the time and space to work with them from a psychological perspective? Or would pharmacotherapy support, you know, also help them? And I suppose I would, you know, as somebody who's worked with people, I have a very open hand about, you know, you can have the medication that can support, you can have the therapy support. One doesn't work for, you know, everybody. But I suppose what I would really encourage is that instead of prescribing straight away a pharmacotherapy support, is to think about how maybe somebody would like to talk about it with their anxiety. And I suppose one of the common fears, and I thought this was very good from the research, is because when I've worked with people, this was something they would bring up. You know, they talked about the fear of choking to death. And in a European study, this is research that's been done between the UK and Germany, they said, you know, no patient actually choked to death. You know, so death is a process, and it is going to be different. And there, you know, it's not always this lovely, you know, peaceful thing. But I suppose if you have research to back up around fears around choking, or you can talk as a healthcare professional about what you've experienced and how you've seen people die, you know, that can really help the person. So we've talked a bit about anxiety. I'd also like to talk about depression and a sense of hopelessness. So what do you think, you know, if, you know, because you're working in this area, how would you support somebody, you know, you're working in palliative care, working in the health services, who presents to you as you're thinking they seem a bit depressed? How would you support them? Listen to them, yeah.
Make a referral to the appropriate services to do.
Yeah, make referrals. Anybody else?
Find out what gives them meaning or what, you know, what their passions are.
Yeah.
Quite often they can't communicate.
Yeah.
It's their care, their spouse is scary.
Yeah.
Must be very difficult.
Yeah, must be very difficult. Yeah. Anybody else?
Be honest.
Yeah. Okay. So you've all talked about it. As I said, it's not something you're not doing, but you know, make sure you support them to talk about how they're feeling. You might notice somebody is withdrawn, you know, avoiding situations and people, especially, you know, they may have had a very good social network support and now they're distancing themselves, you know. So just to be aware of the little triggers. It's very important that you encourage somebody who is feeling depressed to be very kind to themselves, because often with depression comes a very, very critical sense of themselves. You know, I should not be feeling like this, or, you know, what is this like for my family? Because, you know, not only now do I have motor neuron disease, but now I'm feeling very depressed, and what's the impact like on others? So, you know, it's, as somebody said, allow them to say, you know, it's okay, you know, it's actually very normal. You know, I'd be surprised if you weren't feeling that way. And you know, people can feel sad, resentful, they can feel very angry. And for some people, they will be angry right up until the day they die. For some people, they will come through like depression, anger, sadness, and they may come to some, I don't know whether you can say acceptance. I don't think you could accept that you have motor neuron disease, but maybe you have a bit of an ability to try and live each day with it. It's very important around depression as well, and we've talked a lot about physical symptoms this morning, that it isn't due to something else, that there isn't another trigger, you know, because, you know, we were talking about the cough assist and the coughing and how, you know, anxiety provoking that is, talking about the breathing, you know, making sure it's not something else as well, that if you could sort it out, that would really help them as well. And you know, as somebody said, is to look at a referral. They don't have to go through this alone, you know. And so, as a healthcare professional, I'd really encourage you to, you know, when you see it and you're triggered by it, and you know, often when you're working with somebody, you know, you'll notice that you'll feel this real like sense of sadness and loneliness. Even the way I'm talking about it now, I'm just noticing in the room. You know, because we have that ability, because we're all connected, we do pick up on things and we're connecting to things. So it's just using yourself as well. And when you feel like, woo, that was really tough, you know, then that possibly is going on times 10 for the person that you're working with. So just to be aware of it. And that they can get support. And that's what's, you know, hopefully I'm a real advocate of that, is that in the multidisciplinary teams within palliative care and end-of-life care needs to have the psychosocial, psychological support mechanisms in there. Now, often, and you know, John mentioned it as well in relation to ventilation, is you know, people can have suicidal ideation. They can say, I want to hasten death, you know. So how would you support somebody in that? Because if you're working in palliative care, this is something you've probably come across before, working with people. So how do you work with that?
I suppose it's similar to how you respond to someone with depressive or anxiety. I suppose there's more of a timeliness around this end of things, but the concept is very similar around making sure they're supported and are allowed to express how they're feeling. Yeah. And I think, yes, exactly. They have a right to express how they feel. And often, you know, when people talk about, you know, that they've had suicidal thoughts, you know, our natural reaction is, oh, yeah, everything's fine, it'll be grand, you'll be fine, you know, But this is the way that person is feeling now. And just for you to give them space to say it, they may not have said it to anybody else. They may not have wanted to say it to a family member. And as a healthcare professional, you have a lot of access to somebody in different, and it could be just that little word where they just feel, I just want to say it because I've been holding it and I've just been holding it inside. So it's really important that you allow them to express what they're feeling and, you know, validate their right to express it. And it's, you know, it's not a sign of failure that they're expressing this. Remain involved with the person, but it's very important that you also maintain your professional boundary. And if you do not feel comfortable, because this may be need for a referral, make sure you do that. But, you know, don't distance, because, you know, these things are quite difficult for all of us. So we tend to, you know, go in and out of it. So just to make sure, you know, you get the appropriate support. And make sure you discuss it with your team if there is a need for additional support. Okay. Because often, when I've worked with people, they just want to talk about it. They just want to have the space to talk about it, work it through. For some people, yes, it may be something that they want to act on, or they want to hasten their death, or the next time you see them, that's not the case. So it's just important that you do, if somebody says it when you're working with them, is just validate what they're thinking. If you're not feeling comfortable, make sure you get the team involved, you know, and to do it in a way that's caring and supportive and not overly emotional or reactive. You know, it's very normal what the person is going through. So, and I know today we were talking a bit about cognitive impairment, and around 40% or so of people may have some cognitive impairment, and a lesser percent would have a more extreme version of that. But it's important as well to note that, because I suppose working with people, not everybody will have cognitive impairment. So it's not to assume that. But if you are working, and if you have worked and been with people with cognitive impairment, if it is at a kind of a more advanced level, you will notice it with the behaviour. It will be much more erratic, and it can be very, very hard on the family members as well. So it's to be very aware of that. So what I would really say, you know, it's your opportunity to support the carers specifically and the person to know that their behavioural changes are not deliberate. You know, because sometimes with the cognitive impairment, they can become, you know, they say, I don't know who this person is. and they can have very risky behaviour or very different behaviour, and it can be very distressing for people if you have at the more kind of extreme level. Try and support the person to maintain their autonomy if at all possible. You know, split the tasks, avoid distractions. You know, frontotemporal dementia is similar if you're working with somebody with dementia, is to making sure you have, you know, the transitions within hospice, acute hospices and hospices, that the transition is very supportive for the person. The environment is very important. How you're speaking, how you're giving space and talk. Create that environment. Remove any stresses or triggers. You know, notice what supports the person or doesn't, and try and relieve their agitation. So, I suppose a kind of final thing, because I'm just getting the thing there that I have 5 minutes left, is, you know, as healthcare professionals, you're working in an area, you have a lot of demands on your time, you know, and it's very important that you know your limits. You know, I thought that's very good. I nurture myself so I can nurture others, because often healthcare professionals aren't so good sometimes at looking after themselves, and it is very important that you do that you know your limits of your ability. I don't feel comfortable, whatever, I'll get the team, and that you build that team support around you so that you're never in this alone. And because it can be very challenging, and research has shown that. You know, for the family, for carers, it's an extremely challenging time for them as well. So just to be aware of that. Important to recognise your limits. Try not to go over them. If you're going past them, then, you know, it's very important. Share your experience with the team. Support each other. All very important things, I think. Especially, I know when I'm working in the area, the support I got from other team members and supervision support allows me then to work with people. Otherwise, I wouldn't be able to do that. So it's a full team of people behind you. And I suppose why I really want to finish on is psychosocial care is an opportunity for every single person here today. Okay? You can all provide psychosocial care for someone with MND. They arise at any time, and it's particularly when you're having discussions around care decisions or discussing symptoms. So you may provide a small amount of care and you may refer on or whatever, but you can all provide something for the person. Because it's a really good time, I suppose, for them to talk through their feelings and issues. So be very aware of that. You know, I think Marie mentioned very well about the needing to, you know, digest when it was suggested about certain interventions and get in the space rather than things coming out in the post. You know, just being very aware of it. And I suppose finally, I'd just like to finish on, you know, the person with MND, their families and carers are coping. Their way of coping is their way. And they're trying to cope in a very, very difficult situation. So I'd just like to finish on that and really thank you for your time and attention. Thank you.